In these situations,
from Roma Catholic University, he's also a world expert on this area, and I believe he prefers, or he has done a lot of anterior approaches, anterior decompressions. So we're going to hear the other side of the coin. Massimiliano, please.
Thank you so much for your introduction, and I will show. Very good. Thank you so much. Thank you. First of all, for the invitation. Second, to have the opportunity to share with you my experience, to meet again you all that are very friend of mine. That is a good opportunity to learn for me something more. Dealing with basilar impression, which is one of the abnormalities of the foramen magnum, along with atlantoaxial instability issue that we can find in many embryological books and articles dealing with mainly congenital abnormalities, but also acquired abnormalities are responsible for basilar invagination. The key word of basilar invagination is a crowding of a posterior cranial fossa, and the origin can be congenital or acquired. When congenital, the terminology which is suggested is invagination, basilar invagination. Otherwise, when we deal with the acquired condition, we prefer to use basilar impression. Basilar invagination or impression is a vertical subluxation. According to my very friend Atul Goel, it is also called like a transatlantic herniation. According to Riccardo Bohello, is a kyphosis of the craniovertebral junction. Many words to say basilar invagination to explain the same concept, but from a different point of view. Basilar invagination, platybasia, basilar impression are important feature of quite a similar pathological finding. According to the beautiful presentation of Riccardo, when we have an invagination of the odontoid more than 5 millimeters at McGregor line, or more than 3 millimeters in Chamberlain line, or even of only 1 millimeter in McRae line, we deal with basilar invagination. And congenital basilar invagination is mainly associated with platybasia, atalo-occipital acetylation, hindbrain herniation, Chiari malformation. Otherwise, secondary forms are more likely associated with degenerative inflammatory bone disease, Paget, osteogenesis imperfecta, rickettsiosis, hyperparathyroidism, rheumatoid arthritis. But if we go back to the embryology, we can consider two types of basilar invagination. Anterior basilar invagination, more likely associated with platybasia. The angle between the anterior cranial fossa and clavicle is more than 130 degrees, and in this occasion, the odontoid is retroversed because of a mechanical obstacle in the odontoid vertical growth. Otherwise, when we deal with a disease of posterior cranial fossa on the lower part of the squama, the basilar invagination is called posterior. This is a typical congenital, not reducible, not unstable basilar invagination that Riccardo called like type 2. And more likely this malformation is associated with a tonsillary herniation or Chiari formation that we recognize like type 1.5 according to the worldwide accepted classification. Chiari malformation, basilar invagination, two important concepts, two different terms for the same pathophysiological disease. As we know, Chiari is due to compression and traction as well. Among compression group, abnormality of the upper cervical spine is responsible for Chiari 1.5. Many papers are published so far dealing with the association of basilar invagination and Chiari 1 malformation. And the most common used technique is anterior and posterior. Anterior, generally transnasal transoral decompression, and posterior decompression and or C1, C2, or C0, C2, or C3 instrumentation infusion. But can basilar invagination produce Chiari formation? We have some papers, very recent one, dealing with the indication of anterior decompression just in case of irreducible odontoid invagination associated with Chiari 1 disease. Atul Goel is in favor of C1, C2 instrumentation and fusion, but Karushin is suggested to consider C1, C2 fusion 100% indicated in the treatment of basilar invagination. The consensus conference of in Milan 2019 speak about the indication of anterior decompression, transnasal, transoral in basilar invagination, irreducible basilar invagination associated with Chiari, otherwise posterior decompression and instrumentation infusion in those cases in which basilar invagination is reducible and, of course, associated with the Chiari 1 malformation. Menezes criteria is very similar to the more modern common strategies. When unreducible decompression and then stabilization infusion. When reducible decompression is not mandatory, but strongly suggested, along with 100% indicated instrumentation and fusion. This is a typical example of lesion requiring traction assessment in order to rule out reducibility from irreducibility, like in this case. And again, from the group of anterior decompression for irreducible basilar invagination, transoral decompression for sure is so far again an evergreen gold standard option. Otherwise, in a reducible group, a functional decompression can be strongly indicated. This is a case I will show later on. I published in 2003. I call it functional decompression. And in this case, I preferred in past a huge craniocervical decompression. Otherwise, the goal functional decompression is by definition a short fixation C1, C2, instrumentation and fusion. Some example of personal experience, starting when we began to use endoscopy in transnasal and transoral surgery, and by means of both endoscopy and microsurgery, we started to remove irreducible basilar invagination by isolating and drilling the odontoid. This is one of our very first cases of a 50-year-old patient harboring basilar invagination, Chiari 1 malformation, and oral spinal syringomyelia. This guy was previously operated some years before for the syringomyelia, that in this MRI slide shows some reduction compared to the very beginning of his clinical history, but the basilar invagination associated with the Chiari formation required anterior decompression by means of transoral approach with light traction and extension of the head on the neck by using neuro navigation, and by proceeding with classic Crocard distractor, and by following all the steps-by-steps procedures like subperiosteal isolation of craniovertebral junction complex, we use a very old-fashioned but evergreen empiric system, filling the surgical cavity with contrast medium, Yopamire. And you see here the shadow of the odontoid removed, and this very simple trick allows up to perfectioning the odontoid removal and allowing satisfactory decompression of the bulbomedullary junction. At the same time, one stage combined posterior approach. Again, the posterior decompression and instrumentation infusion allows us to completely release the complex and decompress the Chiari malformation with good clinical results. But sometimes we can deal with the ossodontoideum that we call ossodontoideum, but it is something different from a simple ossodontoideum. It is a basilar invagination with a tip fracture, and we have dealt with basilar invagination tip fracture associated with platybasia and Chiari-1 malformation and syringomelia as well. And we studied those patients with MRI showing also a huge cervical syringomelia. This patient was operated in a very first attempt to to detecting the filum terminalis in another clinical center without any results. Since the clinical picture was growing and worsening with time, we decided to operate by anterior approach to the patient, and then also to decompress by posterior, one stage combined second approach and instrumentation. And this is one of the steps during surgery with the old-fashioned but evergreen injection of contrast medium in the surgical field, showing a satisfactory decompression. And then the patient was operated by posterior approach with further posterior decompression, instrumentation, and fusion of the patient. But look at 6 months later, what happened. There is a benign, I call it benign regrowth of the odontoid due to the young age of the patient and a very, long, very slow progressive local infection, which is a trigger for bone regrowth compared to the very beginning of the operation. This is the 6 months later on CAT scan demonstration of a regrowth of the bone, and this was not compressive example, but the one I'm going to show you now is a compressive odontoid growth, again with a patient harboring both basilar invagination and platybasia and the Chiari-1 malformation, along with the fusion of C1 and C0. So clearly malformative picture. And in this case, we had a satisfactory decompression of both the odontoid and almost all the clivus, as demonstrated by the star. We were able to reach by transoral approach, by splitting the soft palate, the synchondrosis between the sphenoid bone and the clivus. But few months later on, later on, the patient showed a regrowth of both the odontoid and the clivus, producing again Chiari 1 formation, and the patient was operated the second time from posterior approach. But this is for sure a clear example of type 2, irreducible basilar invagination associated with platybasia, very, very severe platybasia. No one in the world should be able to approach this challenging case by transoral approach, but the only way to deal with this clinical case is to follow the endonasal approach that Kassam presented for the first time in 2005. And you know that Kassam considered the hard palate, the separation, the wall, the natural wall, separating the transoral domain from the transnasal domain with some resistances tissue like the skin of the nose and the cartilage of the nose that can reduce the surgical domain of this challenging surgical theater. And this is another personal observation of basilar invagination with a light platybasia, irreducible, as demonstrated by flexion extension X-rays that was operated with the classic transnasal approach. But during the operation, we had, you can see here, a CSF leakage. The only one I had in my anterior decompression transmucosal technique, the only one. Despite the fact that Kassam proposed a transnasal approach as the only one surgical procedure able to avoid the CSF leakage due to a more favorable exposition, according to his explanation of the upper craniovertebral junction to the surgery. We can see here both the Eustachian tube that divide C0 from C1 from a transnasal anterior viewpoint, and this is the repair with a mucosa flap of the CSF leakage that was performed by the ENT surgeon with whom I co-work since many years. And look at that, this post-op, immediate post-op MRI and CAT scan demonstration of a satisfactory decompression. But you see some days later on that the second MRI examination made when the patient was able to take breakfast by himself to walk without any difficulties, but it was not instrumented because at that time we were used to wait 10 days and 10 days after to perform the craniovertebral junction instrumentation infusion second time, and the patient started to get worse, and the MRI was performed according to the worsening of clinical picture up to the death of the patient due to infection. As a matter of fact, the surgical repair of the CSF fistula was not able to prevent further CSF fistula, and the patient infected with CSF infection, deadly CSF infection. And this is the only deadly case of my transmucosal decompression experience, transnasal approach. And this is the Wolinski approach, submucosal, according to the same surgical route we follow to screwing odontoid to fracture. And this surgical approach has a great drawback. The flute-shaped decompression is not enough to allow a craniovertebral junction satisfactory decompression. We have many cases of simple instrumentation infusion in basilar invagination. Since we start after my experience at the Barrow Neurological Institute with the Volker Sonntag, we start to perform instrumentation infusion technique at the late 19th, and we observed this case of basilar invagination, unstable, associated with pulmomedullary junction contusion and myelopathy. And this basilar invagination was reducible. And at that time, I was very happy to write in my very first paper dealing with posterior instrumentation technique that it was possible to reduce functionally basilar invagination. But this very first patient of this experience had a transient worsening due to the contusion, and probably this personal experience pushed up to pay more attention to this very challenging disease. So we think that according to the literature, in other words, we think that irreducible basilar invagination needs to be decompressed both by transnasal or transoral. No other surgical chance are allowed for basilar invagination. Otherwise, reducible basilar invagination required posterior instrumentation infusion and reduction. And thanks to Volker Sonntag, my master, and I'm very happy and honored to have spent some months at the Barrow. And I really thanks Volker to have teach to me transoral approach and basic posterior instrumentation infusion techniques. Thank you so much for your attention.
Thank you so much, Massimiliano. It was a wonderful overview, very useful, very systematic, very meaningful. You gave very nice insight of the importance of Chiari, the concept of irreducibility and functional decompression. And also, I congratulate you for being honest and showing your nightmare cases, which means that this is not an easy area. So my question for you is just to summarize it is, what is the role for anterior decompression in the treatment of basilar invagination nowadays? And if the endoscope can rehabilitate this Crocard approach?
Yes, I think that it is not a point of view, but it is a rule to decompress when dealing with the irreducible basilar invagination. We have many demonstrations, personal and from the literature, that in light extension and traction fixation, you can get a satisfactory decompression of a bulbomedullary junction. Otherwise, in type 2 basilar invagination associated with a huge, very severe platybasia, the only thing you can do is to decompress. How to decompress? When you deal with a Hoffel platybasia associated with basilar invagination, the only way is transnasal. No chances for transoral, believe me. Otherwise, you have to open the soft palate and remove by drilling the hard palate, or better, you can perform extended oral transmaxillar approach with the Lefort type 2 fracture with the ENT surgeon, maxillofacial surgeon, but this strategy belongs to the past, belongs to our memory. Nowadays, we are in the era of endoscope, of exoscope, and all these strategies allows us to perform a very satisfying decompression with transnasal. Endoscope is useful, but it is not the key 100% of a transoral approach. When I perform transoral, after evaluating the indication of transoral, of course, I prefer microscope because, you know, it's a problem of personal habit, but I feel more comfortable with the microscope, and I have a huge surgical field, almost the double compared with the transnasal. And I like to open 100% soft palate, and in my personal experience, by suturing a soft palate, I have not any complication in long follow-up. No rhinolalia, no swallowing disturbances, but only, in my personal opinion, satisfied the compression of bulbomedullary junction.
Thank you.
Can I ask a question, Oscar?
Yes, please, Mona.
Yeah. Very nice talks, actually. I enjoyed both of your talks. If I want to make a comment, the bradycardia is inevitable to make that we must always do a decompassion in bradycardia. But what do you think, other than bradycardia, what is the percent of irreducible cases? What is the percent?
When we deal with
this is for both of you.
Yeah, good question. Good question, because it's still a question in the sense that I think that I answer your question by remembering the last experience of a child, 11 years old, Down syndrome, I have seen yesterday. This is harboring an apparently reducible basilar invagination, with the little particular that no one performed dynamic X-rays in this patient. This patient was operated twice in 2 different centers. All the surgeons were absolutely sure that this very clear-cut type 1 at MRI and CAT scan shape basilar invagination, but I underline, no one performed dynamic X-rays, and this patient was operated the first time in the south of Italy, posterior decompression, instrumentation infusion without reduction, not possible to reduce. And then it moved to the north of Italy in Geneva, where is a very important center, very expert in pediatric craniovertebral junction malformation. Again, the patient was revisioned for posterior instrumentation, and the patient did not improve. No one performed dynamic X-ray examination. Yesterday evening, I have seen the patient, and I'm convinced myself that the only way is to decompress by transoral without removing both scar and hardware from posterior approach, and to try a rescue surgery by decompression. So the answer is another answer to your question. How many people perform dynamic X-rays 100% of basilar invagination patients? I don't think that many people all over the world completely trust in the reliability of dynamics X-rays. Someone says, many people says, oh no, but for sure is reducible. Don't you see? No platybasia, no retroverted odontoideum. A very simple basilar invagination. There is a distance between C1 and C2. So what do you think? No problem, no doubt about the possibility to reduce. As a matter of fact, many of those patients do not reduce when you operate by posterior approach. Otherwise, you have to perform 100% of dynamics X-ray examination. I think that at least 40% are reducible, completely reducible. And my personal experience, the majority is irreducible.
Yeah,
Ricardo?
actually, you mean 40% are reducible? Did you say this?
40%
are reducible.
Reducible.
Yes. What do you think, Ricardo?
My point of view, the problem is doctors that have a huge amount of disease and a lot of experience. In my mind, I never considered a patient reducible. I think that I have one patient that the atlantoaxial distance became the same. Okay, and then every patient may be a candidate to be reduced. What I see, even in publications, that doctors try to reduce only at the surgery, try to use a prone position to reduce a craniocervical spine. It's not adequate. They should reduce the patient in dorsal decubitus and even make traction and keep calm, wait for the reduce to occur. Then for me, the great majority of the disease may be reduced. I would like to talk about platybasia. Platybasia is a big problem. If the patient has a platybasia, the base of the skull doesn't flex. Then this patient would have the angle of vision to the upper part. The only way to have an horizontal angle of vision is to flex their head to the cervical spine. If you reduce patients with basilar invagination, you will, and platybasia, you will compress by the posterior skull, and the patient will have difficulty in swallowing. Probably 15% of our patients have platybasia. That, for me, is the biggest problem. It's my opinion, Dr. Zileli.
Right. Okay. You know, I saw that none of you were really put a lot of focus or emphasis on C1, C2 distraction and fusion cases, as Atul Go defends. I think it's dealing a lot with unstable patients, and whenever you have instability, you can reduce patients. That's the general rule. And for me, what's appealing in his concept is by using these C1, C2 cages, you can somehow increase the height of the cranial vertebral junction. So bring the odontoid down or the atlas up, doesn't matter. And if you use a lordotic cage, you can also mitigate some of the kyphosis that it's part of the problem. And also when you do a C1 posterior fixation, this is also a kyphotic surgery. So I look at his theory as his philosophy as a very interesting one. So you can increase height, and using somehow a lordotic cage, you can give some lordosis to the segment. What do you guys think about that?
Let the results show the data. We don't have data.
Okay. Okay.
I have an idea.
You have an echo.
Yes, I turn off. I have a personal conviction that when we deal with congenital platybasia and the type 2 basilar invagination, no doubt that it is not reducible, because we know, and there is not any increase of C1, C2 distance. But the problem arises when we deal with secondary basilar invagination. And as we know, secondary basilar invagination can be due to hyperparathyroidism, Paget disease, rickettsiosis, osteogenesis imperfecta. And we know that when one of these diseases develops in different subjects counteract this disease in different manner. The young counteract the disease in a different manner compared to the older one. the osteoporotic in a different manner, the one who has a trauma over the basilar invagination in a different manner. So I think that we should tailor the judgment of consider stable or unstable, the same kind of, by definition, unstable basilar invagination, because the body and the age counteract and behave in a different way, in a different manner. Many times I realize in the operating room that a basilar invagination that I consider absolutely reducible, even in the light of dynamic X-rays preoperatively performed, I realized that things are not so simple. And I also studied very deeply the position of the head to the neck and of the neck to the chest. I published also a paper. I showed you the first page in Acta Neurochirurgica, if I'm not wrong, in 2000 and I think 2 or 3, when I titled the always posterior strategy, because at that time I was convinced that 100% of 100%, a big number of so-called irreducible C1, C2 dislocation were reducible with a special maneuver of reduction. But with time, at 15 years later on, with time, my experience a little bit changed, and I'm not so sure that it's possible to reduce the majority of basilar invagination. Anyway, we work in different parts of the world with different races of human beings, with different degree of cure, of feeding condition. And so the bone can change, and you know, many things must to be put in the pot to
Massimiliano.
Conclusion.
Great. So Massimiliano and Ricardo, I have a little trick for you. Okay, can I show it?
Okay.
Very quickly. You know, this is one case that I have to deal with. Okay, and you know, it's a 62-year-old female, neck pain, some myelopathy, lower cranial nerve dysfunction, dysphonia and swallowing, and this is what you see here on this MRI. And of course, there is platybasia, which is something we don't see a lot in our patients here in Portugal. Craniovertebral junction deformity, compression. You wonder if there is Chiari associated. So I think my patient is going to be very, very happy because I'm putting this to discussion, and I have the input of Ricardo and of Massimiliano. This is the flexion extension X-ray. As you said, Massimiliano, we cannot say anything about this. I fully agree with you. This is just some anatomy of the bone to show you. So, should we go? I'm not sure I'm happy with Ricardo only decompression. He showed us some cases where he did decompression, but there is still a lot of kyphosis between the medulla and the spinal cord, and I don't think this is good. And I don't want to go anteriorly as Massimiliano and have some problems with infection, CNSF leak, and death of the patient. So, guys, what can you discuss about this patient? What do you think it would be suitable, Ricardo?
Okay, Oscar, that's a good case. In fact, there is a platybasia, but if you look at the amount of anterior compression, is the same of my patients. And I try to do a big decompression. I remove the posterior fossa bone. And the majority of our patients, and I use an extra-arachnoidal approach. I remain intact, the cisterna magna. And cases like that, in my experience, can be treated by posterior approach only. I just would be okay. That's what I would do at first.
And no fixation, no posterior fixation.
No fixation.
No and what about you, Massimiliano?
I completely agree with Ricardo. Although I like, anterior decompression technique, in this case, a transnasal should be strongly indicated. I'm sure that the patient health first. So I think that we could try, for sure, the posterior cranial fossa is crowded, no doubt about that. And it is crowded because of anterior compression, no doubt about that. But the aim of our surgery is to decompress posterior cranial fossa. So you can decompress posterior cranial fossa both by anterior approach, and this is an etiological surgical treatment, or second choice, or same choice, by posterior decompression without instrumentation and infusion, because there is no evidence of instability, and this we could call as symptomatic surgical treatment. Etiologic one is transnasal, symptomatic one is posterior decompression. All the approach go forward to a clinical benefit to the patient. That means the compression of posterior cranial fossa. So I should start with decompression, posterior decompression without fusion, and will follow in the time the patient.
Okay, guys. Thank you. I think my patient will be happy. So, any further questions here from the chat? I have here your technique, anterior and posterior approach is very useful, and case examples are very good. What do you think for transatlantal resection of odontoid and instrumentation for only posterior approaches for severe basilar invagination? Is it possible?
My answer is I don't know. I don't know.
I'm sorry, I don't understand what kind of a transatlantic decompression.
So, Guven, can you explain to us?
Okay. Thank you for wonderful presentation. We used to try like that with posterior approach C1, C2, but we think if it's possible, really we don't know, we don't try any cases, but we make some experimental study for odontoid resections. If it's possible, if we drill half of the C1 to reach to odontoid processes or transatlantal approach for odontoid resection instead of anterior and posterior approach, only for us posterior approach.
Very interesting.
Interesting. Any further question? Onur, you are the boss.
Oscar.
Yes. Do you have any question?
No, there are two very experienced surgeons here. So we're just listening and we're trying to learn something from them.
We did a lot. We learned a lot. So Mehmet, can we close the webinar?
Yeah, actually, I want to comment one thing only. There are actually some surgeons, especially from China, who are doing the irreducible cases by making some small osteotomies a reducible case. So then it may be done with an anterior approach or posterior approach. So then a reducible case may be improved to a irreducible case, may be improved to an reducible case. So then make a fixation at the end. This is the new trend, I think. We should look at that in the future. Thank you for joining us, and thank you for giving very, very nice lectures.
Thank you. So it was, I remind you, a joint venture between the Middle East Spine Society, WFNS Spine Committee, and International Academy of Spine. So I thank you so much for being here, bring your input and the participants to be so enthusiastic. Thank you so much.
Thanks
Bye-bye.
a lot.
Thank you. Bye-bye.
Very
Bye-bye.
good. Wish to see you again in the next meeting.
Yes,
Okay.
for sure.
Nice to see all you.
Thank you.
Bye.